Welcome, everyone, and thank you for joining us for this special event honoring Black History Month, featuring an inspiring conversation with distinguished author and activist Harriet Washington. I'm Dr. Medell Briggs-Melanson, Chief of Health Equity, Diversity, and Inclusion for the UCLA Hospital System and Associate Professor of Emergency Medicine at the David Geffen School of Medicine. To start off, we're going to go with a little bit of a few programming notes. All of our program attendees have been placed on mute, and this program will be recorded, and the video will be available soon on the UCLA Health website as well as the YouTube channel. Now, this year's theme for Black History Month is Black Health and Wellness. This theme could not have been more timely as we continue to focus our efforts on the root causes of health inequities and social injustices that continue to disproportionately impact Black bodies and Black spaces. Tonight's discussion, which is sponsored by the UCLA Health, Black Leadership Coalition, the Office of Health Equity, Diversity, and Inclusion, and the Office of Justice, Equity, Diversity, and Inclusion, will highlight the contributions of scientific racism to persistent health and healthcare inequities that impact not only Black people, but also the overall BIPOC community. And also, we are really going to center our focus on the responsibilities that we have as an academic medical center to combat racism in clinical care, education, research, and our overall work and learning spaces. Well, before we begin, we of course are a land-grant institution. So UCLA Health acknowledges our presence on the traditional, ancestral, and unceded territory of the Gabrielino Tongva peoples. We pay respect to the ancestors, elders, and relatives, past, present, and emerging. Let's go ahead and get started for tonight's program. I would like to introduce you to our moderator this evening, Michael Whittier. Michael is the inaugural Director for Health Equity, Diversity, and Inclusion for UCLA Hospital and Clinic System. Michael has a vast experience advancing health equity as well as racial equity in healthcare. His past leadership includes roles in other academic medical centers, as well as at St. Louis Integrated Health Network, where he worked to advance racial equity and care coordination across a network of hospitals, medical schools, federally qualified healthcare centers, and public health departments for divested demographics in the St. Louis region. This work was established and subsequently developed out of recommendations by the Ferguson Commission and reports developed after the killing of Michael Brown Jr. He has been instrumental in my office, the Office of Health Equity, Diversity, and Inclusion, as well as throughout the entire organization in order to help to develop and implement the UCLA Hospital System strategies and initiatives to uphold principles of inclusivity and equity throughout our organization. Please welcome me in welcoming Michael.
Thank you, Dr. Briggs, for that warm welcome. And we're really excited about the conversation we're going to have. I think that the overview of today's event is just on par with a lot of things that we're experiencing through the pandemic and just through the recent social events that have unfolded in our country. And so we're really excited to just really celebrate Black History Month and all that it entails for Black health and wellness. And so as Dr. Briggs-Melanson mentioned, we're really going to dive into scientific racism and its impact that it has had on American medicine, racism, and how it has developed over time, but then also health inequities and how they have persisted today. And so about our speaker, Harriet A. Washington is a prolific science writer, editor, and ethicist who is the author of the seminal medical Apartheid, the Dark History of Medical Experimentation on Black Americans from Colonial Times to the Present, which won a National Books Critics Circle Award, the Penn Oakland Award, and the American Library Association Black Caucus Nonfiction Award, and 5 other well-received books, including A Terrible Thing to Waste, Environmental Racism and its Assault on the American Mind, as well as Carte Blanche, The Erosion of Informed Consent in Medical Research, which was published this past year in 2021 by Columbia Global Reports. As a medical ethicist, Harriet Washington has a unique and courageous voice and deconstructs the politics around medical issues. In addition to giving an abundance of historically accurate information on scientific racism, she paints a powerful and disturbing portrait of medicine, race, sex, and the abuse of power by telling individual human stories. Washington also makes the case for broader political consciousness of science and technology, challenging audiences to see the world differently and challenge established paradigms in the history of medicine. So without further ado, I would like to welcome Harriet Washington.
Thank you very much, Michael. I'm thrilled to be joining you here tonight. Thank you for having me.
Now, we are so excited for having you here, and we can learn so much. And so I really just want to jump into the conversation because I know you have so much to offer us, so much wisdom to provide. I think your books are absolutely fantastic, and they have aged very, very well. And so with that, you have been highlighting the dark history of medical research throughout your career. And I just want to jump in with what are some of the more profound findings that are still relevant today for you as you observe healthcare, medical research in everything that we see unfolding today?
One of the first realizations that I had to experience and that many of my auditors have to understand is that two disciplines that we traditionally think of as being unimpugnable, history and science, are not as perfect as we'd like to think. Unfortunately, we fall into this mindset where we say, it's a scientific fact, you have to accept it. Historical fact, you can't argue with it. But we can't forget that history and science are conducted by people, and people bring with them their own limitations, biases, and opinions, even propaganda and political animus. And so a lot of what we had been received as scientific facts and historical facts, in fact, the canon of the history of medicine has been carefully curated to elide the experiences of African Americans, so that African Americans don't appear in the canon. And when they do appear, rarely, they tend to be blamed for their own illnesses, blamed for their own medical misfortunes. They appear in a very non-complimentary way, a very propagandistic way, not at all predicated upon scientific data that's been analyzed. But we're really looking at medical mythologies that are as old as human culture. The Roman physician Galen in ancient Rome said that African men had oversized genitalia and undersized brains. That does not differ very much from what we heard from the 19th century scientists in this country. The best scientists in the country got together to agree that African Americans were unintelligent, sexually aggressive, had only childlike judgment, had profoundly different and profoundly flawed bodies, had diseases that white people didn't have, had immunity to disease that white people didn't have, and every one of these beliefs exists today. It'd be great to be able to say that we've left that in the past, but we have not. Numerous studies. One example is a 2016 study, University of Virginia, showed that half of all medical students who responded thought that Black people did not feel pain the way whites do. They're learning this part of their medical training, and a good number of practicing physicians think this as well. These are still with us. So that's the most important thing that people have to understand, that this history is predicated on racism, not race, and on mythology, not science. Despite the label of science or the label of history, it's not what we're looking at. And the other thing to understand is that economics and politics had a very strong hand in determining not only characterization of who Black people were, but also their treatment. So science looked at people and divided them into races, not on the basis of scientific evidence, but on the basis of politics. Europeans went to foreign countries full of people of color. They wanted to colonize them, dominate them, conquer them, commit genocide. And in order to do that, it was convenient to say that, well, these are not really people. These are inferior beings. And science was very happy to agree with that. There wasn't data to support that, but they didn't need data. And what happened was, as time went on, from say the 17th to the 19th century, you began to have science as a predominant way of knowing. So now what scientists did was they basically threw a veil of scientific data over the same beliefs. And so making it look like they were scientific beliefs, but they certainly are not. That's really important to understand. Racism created race. Race is not something that exists independently. It's something that was superimposed on people. And the mythologies are things we still deal with in the era of COVID. We're still fighting the same mythologies about bodies of Black people, and it's still interfering with our ability to heal them properly in COVID. And then, of course, there are so many other things, but another thing that really struck me was how frequently racial abuse and appropriation of Black bodies is a traveling partner of fraud. Scientific fraud is very common. When scientists began to need data to support their beliefs, they simply invented it, or they distorted it, or they made it up. And so, abusing data in that way is something that we commonly find to justify viewing people of color as being inferior. We continue doing that today, especially in the developing world. And then how very illogical these beliefs were. Even like the slightest scientific scrutiny, they don't stand up. For example, scientists were certain and told everyone that Black bodies were so different from white bodies that Black people belonged to a different species. And yet, when they conducted research on Black bodies, they would extrapolate it to white people, which is totally illogical. So the way that medicine and science had been betrayed by people with a racist agenda is striking. And even more striking is the fact that we can see evidence of that today. We haven't lost it, and it's not going to go away by itself. We're going to have a full-fledged assault on this. It's going to take intentional action by everybody to root it out.
No, thank you for that. And you shared so many fabulous points. I really love racism created race. Because when we think about it, and we know race is a social construct, but we don't think about it in terms of the proliferation of scientific racism and how that created race. So thank you for sharing that, Jim. And you also really mentioned the economics and politics, thinking about the creation and the formation of this country and the earliest efforts for advancing health equity policy was the pushback was, no, our democracy is too fragile, separation of state versus federal government. And so we cannot forget that the history and science are made up. And so with that, I think that your 2006 publication of Medical Apartheid really explores this in great detail. And you really talk through the racially segregated systems of medicine that exists here in this country. And you particularly noted race, culture, and economics have trumped medical and scientific truths. And so thinking about health inequities today, how has and in what ways has race, culture, and economics really overshadowed health inequities as we observe today?
In a myriad of ways. There's no time to go into every single one, but it's everywhere. The things that that presented to us as science actually are often, politics and racist politics. And when we look at the data, racism causes data to be distorted. I think that one of the really important things to realize is that if you go back to 19th century, where 90% of Black people were still people who had been imported from Africa, where they were living in the South. And you found that they were very frank at that time. Scientists did not hide the fact that they were relying upon their beliefs rather than science. That took a bit of time for science to begin to try to justify their beliefs. So what did you have? You had healthcare systems, something I don't think is actually understood enough. We talk about healthcare for Black people and white people, but what we don't talk about is that the gains, the goals, the intentions of healthcare were very different. For white people, the Western patient-physician dyad, where you had a doctor who was motivated by a strong sense of love for the patient, responsibility, scientific acumen, and a patient who trusted the doctor completely, was very honest with them. It's a beautiful relationship. It had nothing to do with the relationship between doctors and African Americans. For African Americans, typically enslaved, typically on plantations, they saw a doctor when? Only when their owner deemed it necessary. Doctors' memoirs were full of accounts of complaints about how they're called in to see a slave only at the last minute when the slave is already at death's door. And so planters didn't want to pay for medical care. They would dose the slaves themselves or ignore them, make them work while they were sick, and only in extremis would they call in the doctor. But then the doctor's job was what? Not to listen to the slave talk about his illness and, what kind of, result he wanted and give permission, withhold permission for care. No, the planter did all that. The planter told the doctor, this is what I want to happen. This is what I'm willing to pay. This is what I'm willing to say yes to or say no to. Everything from amputations to treatment for malaria or yellow fever was at the behest of the owner. And so the doctor had to satisfy the owner. The opinions of the slave were completely irrelevant. Nobody listened. Nobody cared what that person wanted. And so you had a system that was predicated on preserving the fitness for work of Black people, not their health. And there are many, many conditions that are compatible with fitness for work. You could be profoundly depressed. You could be ridden with parasites. You could have a number of chronic illnesses, including sickle cell disease, that would be completely ignored until they interfere with their ability to work. And so that mentality, unfortunately, has perpetrated today. What do we often hear about the care of African Americans and even of the poor? There's a division into people who deserve care and people who don't deserve care, and discussions of cost. I make note of how frequently questions about the cost come into play only when we're talking about people of color. And that's a direct consequence of the, historical and persistent belief that it is preserving fitness for work that's important. In this country, we do something that I consider very bizarre. If you compare us to other countries, how do we get health insurance in this country? What's one of the predominant ways of getting health insurance? Certainly before Affordable Care Act, but even now, through employment. Why? Why should you only have access to healthcare if you're employed? Other countries think that's completely insane. And it is completely insane unless you understand the history. Again, so I often point out that during the 19th century, doctors would be paid maybe $1 to treat a slave for malaria, maybe $1 to set a slave's broken leg, but they would make $50 to testify as to whether a slave was fit for work or not. If you bought a slave and then you discover the slave can't really work as well as you thought, you would hire a doctor, you'd go to court, and you'd try to prove that the slave was sold to you on the pretense they could work and they really couldn't work. And doctors are paid handsomely for testifying there. That's an indication of their real value and the real intent of healthcare when it comes to African Americans. So we're still suffering under that. There's much more, but these are some very basic and very early mindsets that we still have not shaken off, and we still don't actually recognize to the extent that we should.
No, that's so fascinating, and it really speaks to the value that we placed on human beings' lives, but then also the value in consequence that we've placed on the word of providers and the word of doctors. And one quote from Medical Apartheid that I really loved of yours, Harriet, was most perpetrators have been overachieving adepts with sterling reputations, impressive credentials, and social skills sufficient to secure positions of great responsibility. And so when you think about that, when we think about world-renowned healthcare institutions with fabulous physicians, surgeons, researchers, how do we begin to hold individuals accountable for bias and inequities beyond the non-discrimination policies that exist today?
We can begin by focusing on the welfare of the patient and subject and ceasing to worry about the reputation of the caregiver. Too much of our discourse today is focused on preserving the feelings and the reputations of people who either have or have been accused of abusing patients and using subjects. Oh, you know, maybe he could have been more careful, but let's not, ruin his reputation. Let's not, paint him as a monster. He just didn't know. How often do you see people who are abusive begin to invoke their mental health problems? You see it all the time. I mean, from Karens tearing up Whole Foods to doctors who've been caught abusing or neglecting subjects. And very often it comes out, what was his mental state? He was overworked, whatever. This all might be true. And we should be sensitive to that. But who do we care about? We have to decide who we care about the most. Do we care about the patients and subjects the most, or do we care about the feelings of caregivers who might have made an honest mistake and might not have made an honest mistake? And so if we decide that our principal concern should be patients, that makes our decisions very easy. Because if I want to tell you about something I read. I wrote a book called Infectious Madness. Believe it or not, everything I write does not pertain to medical abuses. This book had to do with unaddressed infectious causes of mental illness. And I talked about the fact that hand washing among surgeons and professionals is adhered to very carefully. They're very careful about this. And I've seen it firsthand. Everybody knows this, but there's always one or two, right? Some people, few and far between, but they're there, do not engage in proper hand washing, proper hygienic. Kind of surprising, but it happens. And in hospitals where that happens, they try to pinpoint this and address it because it leads to prevalence of infections in hospitals. You don't want that. And so a lot of hospitals began appointing certain nurses to monitor surgeons' hand washing and then correct them and even, report them. They didn't do proper hand washing. You can imagine how well that went over, right? A nurse reporting on the surgeon. But one hospital found that if they also began docking the pay of surgeons who didn't engage in appropriate hand washing, then the problem disappeared immediately. And that got me thinking about how rarely we want to think about punitive measures. And I won't even go so far as punitive measures. There need to be consequences for failures to meet standards. And it's my opinion that what we don't do enough of is to enact written standards, make sure everybody knows exactly what they should do in certain situations, make sure everybody know that it's not acceptable to turn away people in pain and call them drug seekers just because they're African American. If you do that, it's more than something to clutch your pearls over or complain about in an op-ed. If you do that, you should be written up. There should be consequence for that. Maybe you shouldn't be able to finish medical school until you demonstrate that you can, treat all patients the same. Maybe you shouldn't be eligible for a promotion, in your academic center. Maybe you should not take them a full paycheck. There need to be real consequences. Until we start doing things like that and thinking in that manner, I don't think we can hope to see large-scale change. People have to come to view these shortcomings as not just cruel things that are done to people because their skin color is different and cruel things you do to certain patients and subjects. They need to think about that as a quality control issue. No one should be treated in this manner. And there should be written policies dictating what happens to people who do that. And I think that until we're willing to do that, until we're willing to put the welfare of patients and subjects above the feelings of caregivers, some caregivers, we're talking about a small minority, but unfortunately, it's all you need to cause a problem, then I don't think we're going to make as much progress as we want to see.
Certainly, and I appreciate all that wisdom. And I don't want to overlook one thing you mentioned in the story about infection. You mentioned the nurse calling out the doctors. And so, in your opinion, how can we create safe environments for those who call out ethical violations in clinical and educational settings rather than ignoring the perpetrators of racism. And you mentioned it a little bit, but I want to make sure we don't gloss over that bit about creating a safe environment for those calling it out.
That's a very important question. But I do want to back up for 1 second and first say that it's an important question, but I think we also, in fact, I know, we also are often facing an illogical division of labor. I think it's illogical to ask nurses to correct surgeons in the operating theater. It's not really fair to them for reasons that are apparent to everybody. The relative power held by these two people and the cultural frictions work against the nurse who's trying to do his or her job. So, we see this often. Like another good example of that is when it comes to medical research informing patients about a medical study, giving them information they need to know for informed consent. Right now, we indicate that it's the researcher whose job it is to tell the subject all about the study. I think that's also illogical. The researcher thinks the study is a very positive thing he's doing. He expects it to be beneficial. He is, or she is fully in favor of it. And asking that person to give objective information to a subject is not logical. They're much more likely to end up selling that study to the subject, not because they have a venal mentality, but because, they are invested in the study. It makes a lot more sense to have someone independent of the study tell the subject. So to get back to your question about how to protect the whistleblowers, that's a very important question. And first of all, we should put thought into who this whistleblower should be. A whistleblower is someone who comes forward, voluntarily. An appointed person is someone that we appoint to do reporting, right? I think we need to rethink who we appoint to do the reporting, but someone who comes forward voluntarily, I think there are a lot of things we have to do that we don't necessarily do now. One of them is the director of departments, the criterion by which you choose these people should include a dedication to the changes that we want to see. That should be a qualification like any other. And hopefully that means, when the head of department is invested in something, that will trickle down. Others will also become invested in it, either because they truly care or because they truly care about having the head of department behind them, right? So that will help, but it's not enough. We also need to have a system, a formal system in place for people who want to report a problem. There should be an advocate who does not have divided loyalties, right? Often in hospitals, good intentions, appointing advocates, but at some point, they have to, are you working for the hospital or are you working for the patient or subject, right? So for whistleblowers, we need independent advocates, ideally someone not employed by the hospital, a consultant who will be present as the whistleblower, makes known their concerns and will be present and be their advocate at every step in the process. Also, we need to have, again, written policies about what takes place. What I have seen and discussed with friends of mine who work in hospitals and other places too, is that unfortunately, an informal system discourages people from reporting. You'll go to someone, the appropriate person, tell them that X is occurring. I think that's unethical. We got to do something about it. And the person you're reporting it to can very often say things like, oh, that's awful. I'll handle it. I'll talk to him, we'll deal with it. And that's very vague. And often things will stop right there. And so whistleblower is, very fervent. You need someone whose job it is to document everything and make sure that things do not fall down the rabbit hole. There needs to be a clear written process, exactly what happens. The complaint and files, then goes to X, then goes to Y, who sits in on it. And at every step, that advocate should be there for the whistleblower. The reason for that is that so often you read about these whistleblowers and they say that things were, they say that things were just left to die in the vine. It's like an error of omission. At some point, it loses momentum. People begin ignoring the fact that this ever happened. They get no response and they give up. And then two, there is the cultural problem. Within the culture of the institution, whistleblowers are often made to pay for revealing things that, are problematic. And the presence of an advocate who's independent, I hopefully would minimize that. But the bottom line is you need a system in writing, and every step should be documented, and you need at least one person independent of the center itself to be an advocate for that person. And until we make a system like that that protects the whistleblower, then we're going to hear more and more of these sad stories of people being courageous to come forward and yet not having things, addressed because, the indifference, of other people.
Yeah, that's absolutely spot on in my opinion. And so I appreciate that answer, because the environment that we put our workforce in is so troubling. And when we ask people to step up and report incidents as they see them, whether it's a patient being mistreated or a fellow colleague, and this creates that culture that perpetuates racism in institutions. And you really mentioned how this creates these issues, but then also the invented data from scientific studies, and how that perpetuates misinformation, and all of it really boils down to trust and mistrust of the system. And you spoke about a story in medical apartheid of a colleague who wouldn't receive care at the institution you both were working for at that time because of the mistrust or the culture and the scientific racism that had unfolded before that patient or that staff person's eyes. But then there's also several studies that are alluding to larger sample sizes needed to really address racial inequities as it pertains to healthcare and gaps in care as we know it. And so, how do we begin to really address the mistrust in medical research and in care delivery to increase participation in studies and in care altogether?
Well, that's the most frequently asked question I get. It's also the wrong question. When we are concerned about mistrust and we indict the mistrust of African Americans who say that they're not going to engage with the system, unfortunately, by putting the onus on African Americans and their behavior, we're giving the impression that there's something pathological about African Americans' mindset and behavior. In reality, the reluctance of many people to avoid medical care as well as medical research is a tragic but logical reaction to the history. 400 years, African Americans have been consistently demonized, injured, had their bodies appropriated. And these are not things that only happened 400 years ago. These are things that also happened last week or this summer. And so aversion to the system is a logical reaction to that. So I think it makes a lot more sense to talk about an untrustworthy healthcare system. That's what we're dealing with. And frankly, the answer is, people want a quick answer, which I understand. People want something they can do now, fix the problem, and hopefully we'll have it behind us next year. That is not going to happen. It took 400 years for us to get here, and things are not going to be resolved quickly. And so we need to look at a permanent solution and accept that it's going to take some time, and accept that it's not about changing the behavior of African Americans. It's about changing the behavior of the healthcare system. If we have a trustworthy healthcare system, people will flock to it. So that's what we need. Also, it's very problematic that when you ask that question, again, you're implying that it's the mindset of African Americans that needs to be fixed and not the system. And so if you abuse someone for 400 years, and then you deny that you've done it, ignore the fact that you've done it, are they going to trust you? No, that's going to harden their distrust. So, we need to revolutionize the way we think about this and stop thinking about changing African-American behavior. We need to change the healthcare system. And there are things that we can do that we could do tomorrow if we wanted to do. We need to change the system and incorporate African-Americans and other people of color into the system so they'll have more of a sense of ownership in it. Rather, instead of something that happens to them is done to them, it would be very fruitful if African-Americans and other people of color saw the healthcare system as something they were partnering with. And of course, that's a goal too. But, instead of talking about, talking Black people into trusting the system, we need to talk about making the system more trustworthy, eliminating some of the really dramatic ways in which we treat African Americans differently, and eliminating them in a very public way so people will know that they've been eliminated.
Now, thank you for that correction. I think that's a fabulous point. And we sometimes center the patient in the incorrect way. And I think that question really highlights that. Appreciate you redirecting that question to really put onus and accountability on the system. So a follow-up to that, thinking about the system and accountability. And having leaders or staff that really say, it's not my responsibility to advance equity in my role, or I didn't create this problem. This isn't my responsibility to fix it. How do we combat a culture that deflects or rejects accountability and ownership of advancing equity?
Interesting that they don't take that stance to other medical problems. Do they say, I didn't invent terminal kidney disease, what do you want me to do? No, it's a challenge they take on. And so it's part of caring for patients and subjects. If your mindset is not one that allows you to incorporate that responsibility with the purely physical acts you're doing, then I think maybe you shouldn't be in medicine. Interestingly, in the 18th and 19th century, the Africans who came here had a medical system that incorporated social and psychological dimensions. That was part of medicine for them. You not only healed the body, but you healed someone's relationship that might be, causing them stress or anger. They saw it as one and the same. And they saw treating only the body. They said, that's what veterinarians do. That's how you treat animals, not people. And it's taken us 400 years to catch up to them. I mean, now we acknowledge the fact that the spiritual and psychological dimension are very important aspects of medicine. And I don't see how this differs from that. We have a system that unfortunately damages some people rather than helps them. And I fail to understand, frankly, how one can be a physician or a nurse or a healthcare provider and not see that as your responsibility, doing the best job you can to address every dimension.
Certainly, thank you for that answer. And to shift gears a little bit, I really want to talk about vaccines and clinical trials
Oh,
a bit
yes.
briefly. It's hard to ignore
I do
that,
too.
considering where we are today. And in America, in medical apartheid, you highlighted VaxGen's HIV clinical trials. And for the audience today, could you briefly share the significance of that study and its outcomes and subsequent studies that relates to that VaxGen clinical trial?
I will, but if you don't mind, I'm much more interested in what's transpiring today.
No,
Partly because
certainly, please.
that was 15 years ago.
Yeah.
And I'm not as sharp on the details as I was when I wrote the book.
No, no worries.
But what I do recall is at a time when HIV vaccine was the holy grail, and many people were focused on coming up with one, there were a number of near misses. Vaccines we were lucky with COVID-19. I shouldn't say lucky. We were extraordinarily skilled and a bit of luck with COVID-19, but usually vaccines are very, very long, onerous development. So in this case, it was difficult to know exactly what had transpired because very this is not the only company to do it. Sometimes companies will conduct their research, but then only cherry pick the results and only publicize those results that, you know, they want people to read about, what we want people to know about and consider. So in this case, however it happened, the company was talking about early successes that seemed to evaporate. They did, you know, the study they did, published in the New York Times and other newspapers, said that unfortunately they did not come up with desired results. It was not effective. It was not going to be, didn't look like it was going to be an effective vaccine. Disappointment. But in the last paragraph, the very end of a few stories, they mentioned, oh, but you know, we did see positive results in African Americans and some other groups, you know, an afterthought. And I'm like, wait a minute. If African Americans were helped by the vaccine, don't dismiss it and have a story dismissing it, and then you find out in the last sentence that it helped a group, because you have to remember, it's not that unusual for vaccines to be helpful for much that it has happened before that vaccines have helped certain groups more than other groups for a variety of biological factors. So I suppose it's possible that an HIV vaccine could be devised that might be more effective in a certain group. And even though the label African American is there, who knows what's really African Americans? It might have more to do with the environmental factors, something like that. But my point was, don't dismiss it out of hand as if African Americans' medical fate was not important. And I've seen this in a lot of medical reporting. I remember reading stories in the Wall Street Journal discussing the belief that, you know, salt intake did not really affect hypertension enough to worry about. And they gave a lot of data, a lot of discussion. And I got the original article and found out they said that that's true, except in African Americans for whom salt intake should be monitored. That didn't make it into the Wall Street Journal story. That happens quite a bit. That was my major concern there. I had no way of knowing, even after reading the original journal articles, whether or not this vaccine had a chance of showing effectiveness. It might have or might not have, but I did know that the media accounts of it completely dismissed the positive showings among African Americans. And considering the fact that African Americans were not always recruited into clinical trials in sufficient numbers, always a chance that they would have a trial with too few African Americans, and there could be a benefit there and we would never know it. We saw that with AZT. Original tests of AZT showed that it worked well in whites, but not African Americans. So doctors and policy people were saying, do not give African Americans AZT. It doesn't work for them. It doesn't help them, but it could cause side effects. It's going to be worse than useless. No African Americans should take AZT. And this message was promulgated for 2 years. At the end of 2 years, someone said, whoops, we did a better study with more African Americans and it works for them like everybody else. But what's going on now? Now you have Black people who've been told for 2 years, AZT is poison to you, avoid it. And now suddenly you're going to tell them to take it? Predictably, a lot of resistance to it. So, you know, sometimes a medication, including a vaccine, sometimes there are clearly dangerous and clearly unethical aspects to it. But sometimes the unethical aspect has to do with the way that it is promulgated, the way that it's publicized, or the way that it is people are induced to take it, not just the vaccine itself. Just give one more example. Gardasil, a vaccine against cervical cancer, that's a godsend, you know. 20 years ago, we were praying for that. But when we began distributing it, I was deeply concerned because Gardasil, suddenly a lot of lawmakers were saying that, okay, we have to give this vaccine against HPV to young children, you know, 9 years old, because they have to have it before they're sexually active and can be exposed to the virus. And I thought that's not true. 70% of people clear the virus from their bodies once they're infected. And also a lot of people were saying, I don't want my 9-year-old daughter being given something protecting against an STD, certainly not without my knowledge. And I discovered the reason why was that there was a competitive vaccine in Europe, Civarex. And the makers of Gardasil wanted to corner the American market. So they actually contacted female legislators and got them to pass laws mandating Gardasil being given to young girls. It's protective for boys too, but they were only focusing on girls. So that was very unethical. Yeah. And I had a lot of problems with the way it was distributed, even though I had no problems with the vaccine itself. So one has to be careful. I mean, there are many ways in which you can go wrong if you do messaging or distribution that, ignores people's right to informed consent, their right to autonomy, to say yes or no, and that targets people of ethnic or gender groups with no logical basis.
No, thank you. And I appreciate those examples. And I appreciate you jumping to those more recent examples, considering how fast medical research and vaccine research is evolving. And so I think that's an incredible point that we don't want to miss, especially as things evolve, as care innovations are introduced, medical devices are evolving and introduced to care. What measures should academic medical institutions put in place to ensure racial and ethnic gaps are not widened as these things are introduced? For example, what core classes should be integrated into the curriculum, if any, as an example of those measures?
You mean in order to ensure that distribution of these medications and devices is equitable?
Equitable, or they don't create further inequities or unintended
Yeah,
consequences. And we're doing our proper due diligence with the scientific rigor of evaluating the
right.
introduction of these new technologies and care pathways.
Important question, very important question. I think that, frankly, drug design and medical device design, there are a number of possible potholes. I mean, there are many ways in which things can go wrong. And that means that we have to have several layers of protection. And one of them should indeed be in medical education, not with the specifics so much, but I think there are basic errors that keep being made, and medical students should be introduced to them. They should know what's happened in the past and see what kind of logical errors have allowed them to happen. I think that, but then we also need protections later down the line. I think we need protections, frankly, in the law. The way we test these devices and distribute them should be monitored as well and controlled as well, and not left to profit-seeking corporations to determine who's going to have access to them. We're a capitalist society, nothing wrong with making a profit, but there is something wrong with profiteering, trumping the rights and health of people. So to begin with the education process, one of the things that happens very frequently with people of color and other groups of people too, but with people of color in particular, technology often introduces algorithms that sound logical. And the problem is that if you're looking at, dense amounts of data, and that data is being analyzed by a construct, a mathematical construct that you've, say, put into a computer, it looks like it's perfectly objective. How can you claim racism when we're talking about numbers put in a computer? The computer analyzes them easily. The algorithms are written by human beings, and sometimes intentionally and sometimes unintentionally, algorithms can reinforce, separation from the technology. Organ transplantation, there have been a number of requirements. Back in the 80s, a 6-HLA match, human leukocyte antigen match, was considered, necessary. If you didn't have that, you might not have access to an organ. Well, Clive Callender, who ran the transplant center at Howard University, who was tremendously successful in promulgating transplantation technology among African Americans. He knew better, and he and other scientists militated and said, this match is not necessary, but it is separating a lot of people of color from the organs they need. He was right. and eventually that was revised. Today, we have an algorithm that actually, it's hard to believe, this algorithm, I think it's EFGR, I'm probably mangling the acronym, but basically, when you compute it, when you plug the data into the algorithm and you emerge with a value, 1 is added to the value. If you're an African American, you increase it automatically, just because you're African American. Nothing, nothing more about the potential recipient, they're Black. Adding that 1 to the value separates many people from access to the organ. Now you're no longer qualified for the organ. These kind of things happen everywhere. And who's monitoring them? We have these brilliant women who are now interrogating medical technology, women like Ruha Benjamin. There are many more of them. And so they are looking at this and finding numerous examples of how we're doing these purely mathematical algorithms that are actually separating Black people from the care that they need. Also, there are things like facial recognition. And that's really, again, it sounds like it would be objective, it sounds like there'd be no chance to introduce racism in it. But the reality is that studies have shown for a very long time that people are less good at recognizing the face of people of other races. And when you find the worst track record, like among white people, recognize the faces of Black people. How many times have we read newspaper accounts of white people going to court, swearing that the assailant or the criminal or the rapist on trial, that they know that person, they saw that person, only for it to turn out not to be that person. They're not good at identifying the faces of people of color. And so that kind of thing in the medical arena can be a problem as well. All the ways in which we have programmed technologies to incorporate our own biases, often without seeing it. So these are things that we need to systematically interrogate, look at them, see if we're introducing these flaws, and then fix the technology, or at least not use it until it is fixed. So there's a lot of ways at which, a lot of junctures at which we can combat this. Education, when medical students know about this thing, when they know about this recruitment of algorithms to enshrine racism, once they've learned about a few cases, in their practice in the future, they will be better able to recognize it. In the future, 20 years later, someone says, I got this great technology that will allow you to decide who is who's fit to have an organ and who is not. They're going to remember this and think, well, wait a minute, is there any problem here with, bias? And so preparing them in that way is really important, I think.
Certainly, and appreciate that feedback. And so, thinking about some of those challenges, and particularly in the academic setting, what are some of the additional structural racism, excuse me, what are some of those significant challenges with addressing structural racism in those academic settings? And I think you alluded to the technological components, but are there any others in your experience that you've seen that really impact academic medicine?
In terms of introducing racism into academic medicine?
Yes, and combating it.
Okay. Well, there's quite a bit there. Number one problem is denial. Remember, what was it, this summer? The then editor of JAMA did a podcast in which he and another doctor were agreeing that no doctor is racist. So why are we worrying about all this structural bias? It doesn't exist. And that's a shocking statement for me, because I was one of the group that wrote a paper in 2008, and based upon that paper that detailed the history of white and Black physicians in this country, essentially a long history of white physicians excluding Black physicians from academic medicine. And the AMA issued an apology in July of 2008. And after that apology, they had a number of initiatives that have been focused on trying to reduce healthcare disparities. And they worked with the National Medical Association. So the apology was more than just words. They actually put into action things that would help. But now you've got the JAMA editor making this outrageous statement as if all this had never happened. So the denial has to be addressed. The part of the denial is the consistent evocation of systemic racism, which exists. That's what I've written about. That's what I'm most concerned about. But we have to understand that when people talk about implicit bias as a result of that, that exists as well. But there's also explicit bias. And we don't like to talk about that, you know, bias when people openly say things. And one of the things that I've been hearing for at least 30 years, I worked in a psych ED in an upstate teaching hospital in New York, in upstate New York. And I remember having a psychiatric nurse say to me, well, you have to give more psychiatric medicine to this patient. And I said, why? Why does he need more? She said, oh, well, he's Black. And I'm looking at her like, and? And she says, well, Black people have more muscle mass. I said, really? I said, I didn't know that. Can you point me to some data? She became offended when I asked that, right? And then she got very defensive. And she actually ended up by showing me a photograph of her Black husband. Like, oh, okay. But, you know, the thing was, this belief that Black people have more muscle mass is actually a belief held by many doctors still today, held by many caregivers. It's not true. And we need to root it out, but it is an excuse for all kinds of abuses. So academic medicine, you know, part of the problem is that when you have these racist invocations, things like Black people don't feel pain the way whites do. Black people need more radiation than whites do because their bones are harder, their skin is tougher, all kinds of non-scientific, ridiculous, absurd claims. All these things are said, but, you know, they're not found in textbooks. And I hope that no one is saying this in lectures. Where are students learning these things? They are learning them because, you know, the practicing doctors are, you know, taking into consideration. They are not giving pain meds to Black people who are in pain. They are assuming that their Black patients need more radiation. They're learning on the clinical floors when they see, you know, Black person after Black person come in, complain of pain, then be sent away with Tylenol and labeled as drug seeking. When they see, you know, radiology giving 25% more, you know, current to a Black person. When they witness these things, that's a tacit part of their training that they take in. And so it's harder to address because it's not in the textbook, not in the lecture. So part of it has to take place on the clinical floor. And I'm not sure how one does that, except that maybe there should be a species of grand rounds just to address these kind of very common mythological beliefs and practices. And serves as a counterweight to which, you know, residents are going to see. Because right now, there's nobody there to point out that these things are not true. And it's going to be very hard to convince the doctor in training that it's not accurate because everybody's doing it. So I don't know what the answer is, but I know that the answer is not ignoring the fact that this is happening on clinical floors. You know, we've got to take some kind of steps right there to address it.
Yeah, I think that's an incredible point, and we may not always have all the answers, but denying it is certainly not the right answer. And so, no, thank you for that. And I really want to speak to something you noted earlier around informed consent. And in Carte Blanche, your most recent publication, you said informed consent helps us enforce ethical principles of autonomic beneficence and justice. And so just thinking about that and thinking about informed consent and how it's just deteriorated in medical institutions, how can informed consent be restored at the core of American medicine and medical research?
Right. Excellent question. Informed consent actually came out of the principles I talk about, respect for patients, but it's also an essential protection for patients. If you inform the person of all the known risks, then that gives them information that they need to have in order to decide what it's a risk they want to take. So how can we restore it? One of the things, a lot of things have happened to erode it. One of them is that too often physicians look at informed consent as some kind of a signed piece of paper, like something, another box to be checked off, a little task I have to do to get out of the way. They don't view it for what it is, which is an ongoing dialogue that is very voluminous and tells the subject, potential subject, everything that you know that a reasonable person would have to know to make a good decision. And it also involves updating them. If during the study it emerges that the medication being tested has a deleterious effect on redheads, for example, then you have to inform the subject of that. It's an ongoing process. And people look on it as something that, you do once, you rattle off the risks and benefits, and then, you're done. No, you're not. So it's all this pro forma approach to informed consent has to end. The other thing that happens is that there have been a lot of waivers, a lot of, exceptions made. And the exceptions that trouble me the most are the two that were made in 1996. If you look at the Code of Federal Regulations, you will read that if you're unconscious, say a trauma victim, then you can become a research subject without anybody informing you or asking your opinion. And the rationale is that, well, the person's unconscious, you can't give them informed consent. And I read that, I thought, have you ever heard of Nuremberg? I mean, this is completely absurd. Ever since the 1940s, we have decided that, as the Nuremberg Code says, the first tenet says, the voluntary consent of the subject is absolutely essential. Voluntary consent is not redundancy. You can get consent in a lot of ways. You can pay the person a lot of money. You can threaten them. You can, deceive them. Or you can be in an inherently coercive environment like a prison, So you can get consent from people, but the key is it's got to be voluntary. And we don't appreciate that. We also have these for-profit IRBs. And some of them may be doing acceptable work, but too many of them are promising FDA approval very rapidly, and there's no guarantee that they are actually adhering to the rules around informed consent. In fact, a sting operation I described in Carte Blanche found one Coast IRB that was approving a substance they didn't even know what it was. They were told, we're going to dump this liter of this fluid into the abdomen of pregnant women during surgery. They said, okay. And they got it signed off on, they got it approved. And they didn't even know what the substance was. And I'm thinking, no standard, would permit them to do this. So we have to get rid of the for-profit IRBs, in my opinion. They're focused on money and quick approvals and not on safety. But of course, we need to also, the most important thing we have to do is revoke the law that says it's acceptable to withhold informed consent. That should not be part of US law. That's a complete abrogation of basic of medical ethics and human rights. And the ability to do that is very dangerous. When you talk to people who defend it, which is almost everybody in the medical arena, they say to me frequently, oh, it happens very rarely. We don't use that very often. And I'm thinking, it's not a defense. I cannot murder someone and say, well, I very rarely murder people, it's wrong, no matter how often you do it. And in my research, I found that, minimum 40,000 people have been involved in research that they had no consent at all. The term informed consent is used, but I've been using it. But in this case, people are not getting any kind of consent, even the simple right to say yes or no to medical experimentation. So yeah, we have to do that. We also have semantic issues. I wrote a piece for the Journal of Law, Medicine, and Ethics. I talked about the semantics of medical research, and they're really quite powerful. Discussions of medical research have to involve the researcher informing the subject of what's going to be done, as I said. But there are so many ways in which language and jargon can prevent a researcher from conveying to the subject what's really happening and can distort what's happening. All too often, subjects are being told, this is your chance for cutting edge treatment before anybody else gets it. But it's not cutting edge treatment. It's, it's research. Treatment is something that has been demonstrated to help. If you're in the research study, you don't know if it'll help. That's why the study is being conducted. It may help. Researcher may help, hope it's going to help, but it could also harm you. And I've written about numerous studies like artificial blood, polyheme, touted that way. And 26 medical centers, about around 300 people were infused with it without their knowledge. And the people who were given the polyheme had a higher death and heart attack rate than people who got the standard of care. You had people dying in a research study they never knew they were in. So I could go on, but we need to revoke that law. We also need to revise the way in which subjects are informed of the risks of medical research. The researcher should not be the person doing this. There should be an independent person. I also suggested in Medical Apartheid in the last chapter that we need to train research subjects the way we train doctors. When I was a research ethics fellow at Harvard, I had to sign a document saying that, any discovery I made would revert to Harvard, whatever, but I also had to attend a week-long class in which the ethics were spelled out to me very clearly, and a lot of the legal technicalities were explained to us. And subjects don't have they don't have the advantage of that. Subjects don't know anything about the study until they talk to the researcher. The researcher is not, a good person to, in my opinion, explain it because he's got a vested interest in it. He can't be objective. And so I think there should be government courses offered to all subjects, and only after you've taken that course should you be able to sign up for medical research. So there are a lot of things that can be done. I've outlined some of those. I'm sure there are many more, but we need to totally revamp the way we conduct research, and we need to restore informed consent to the forefront of that.
No, thank you. And I think that really segue into one of our questions coming from our audience and thinking about restoring ethics in research. Could you speak more about how research can center Black or African-American people's experiences or health status without pathologizing Black people?
Excellent question. That's the question, right? In my opinion, we do too much research, and in fact, we do too much discourse around medicine in this country that focuses on race. You'll hear people say that race isn't real, and that's not true. Race is real. It's not biological. But the problem with invoking race is that it gives you very little or no information about the individual, but a lot of information that allows you to stereotype them as part of a group. And it's not anybody's fault. It's our culture. It's been inculcated in us that African Americans are a certain way and have certain illnesses and have certain conditions, and the Asians have certain conditions and Asians have certain behaviors. It triggers all that, and I don't think it's not helpful. So I think that what we need to do are more studies that are careful to incorporate proportional representation of everybody. We live in a society, we live in the US where you've got, 13% of the people here approximately are African American. Every study should have that as a goal for recruitment. Same thing for Asian, same thing for Hispanic Americans. It should look like our country. It should look like the population base or the subject base. And instead of I don't think, I'm against most studies that would focus upon African Americans. They have been abused far too frequently, far too much potential, not only for abuse, but for distortions. Look at the AZT study I talked about earlier. Nobody intended to demonize AZT when it came to African American, but that's what happened because of the composition. So, and when we have had studies that only recruited African Americans, bad things have tended to emerge. We're not only talking about the scientific utility, we're talking about culture and psychology and people's behavior. You can't, remove them from the equation. The Beidel study that resulted in the cardiac drug Beidel for congestive heart failure being approved for African Americans only in 2005. But it was based on a great deal of flawed science and very good marketing. And it only permitted African Americans in a study that purported to show that African Americans were helped by Beidel far more frequently than whites. How do you show that when there are no whites in the study? You can't. It's simple logic, it's simple racism. So I don't think that either culturally and socially or in terms of utility, studies of only one racial group, I don't think they're useful. I don't think that they're scientifically accurate. And definitely they're going to be haunted by people's preconceptions. We have a tendency, even among researchers, of conflating biology with genetics. We see what looks like a biological difference, and we very often translate that genetics. It may or may not be driven by genetics, but too often we assume it is. So I think that the fewer assumptions we make in that arena, the better off we are.
Certainly, thank you for that. And there's a question in the chat that's bubbling up that I want your thoughts on. And it is, what is the conversation like regarding reparations for African Americans, specifically in the field of medicine or science, considering the harm that has been done over the years?
I don't know what the conversation is like. It's not actually something I've devoted any attention to. I know people are discussing it, but I'm not aware they're discussing it in a systemic or way, and I don't think that there's any consensus there. I only know what I think about it, and I think that reparations, people often think of money, finance, and the difficulty with money is that we live in America, capitalism, incarnate, but money does not fix everything. There's also the question to me of dignity. I've lived with the stories of people who over centuries have been abused, genocide's been perpetuated on them. Medicine has been betrayed by people who pretended to be researchers, but were actually engaging in torture. When I think about what these people had lived through and how they had been demonized very often, to predicate this, money seems very inadequate, almost, dare I say it, an insult to what happened to them. Certainly, something should be done to achieve atonement. I'm more interested in atonement. Atonement is a concept of you not only admit what you've done wrong, but there's inherent promise to never do it again. I think that's what we need, atonement. And I really would like to see, other resources brought into the conversation besides money. For example, medical education. The peak year for graduating African-American men in medicine was in the 1980s. Their numbers have actually percentage have actually gone down. The increase has only been driven by women. It's good that their numbers are up, but where are the men? So I could certainly see, as part of atonement, a concerted, effective drive to bring more African-American men into the medical arena. Those kind of things have meaning, and they would benefit the victims of the system, but they'd also benefit all Americans too. So I'd like us to think wider than cash when it comes to how are we going to, achieve atonement for the things that we have done wrong.
Now, thank you for that, because I think that's something that we can enact today, right now. And so atonement is something I'm certainly going to take away from this. And so thinking about messaging and marketing and really sharing and amplifying the inequities, but also in the spirit of atonement, have you noticed any healthcare organizations doing a good job of messaging on these topics?
Yes, quite a few, as a matter of fact. And the ones I'm thinking of do more than messaging. They actually put into practice what they're doing. University of Chicago. Back in 2005, I became aware that they were putting into place changes in medical education that I was really impressed by. Before medical school began formally, they had a period of time, I forget whether it was a month, maybe it was like a week, I really don't recall, but it was mandatory and the medical students would gather for classes, but the classes were taught by people like me, not physiologists and not clinical professors. They had people come in who the students were unlikely to otherwise encounter in medical education and talk about, you know, what they have found, what they have, their research, you know, their issues. They had gay physicians come in and talk not only about special challenges to patients who are gay in the system, but their own challenges, you know, getting medical training and socialized as a doctor at a time when homophobia certainly had not disappeared, you know, from the medical community. So I thought it was brilliant because in this way, you had medical students who were inoculated against things they were going to encounter later on. After hearing me, if they heard, as I had heard, when I took human genetics, my professor was convinced that African Americans were less intelligent than whites and was not shy about saying so. If they encounter that in their training, they at least are going to have first heard someone explain why that's not. So they have a chance to like combat it. They are mentally prepared. I love the fact they did that. And I also love the fact that the then chief of division of medicine, Dr. Garcia, had been very vocal and very open. Everybody knew that healthcare disparities were his main, you know, his main focus, that he wanted to see changes. He wanted to see every division addressing it. And because it was his focus, his primary focus, it became everybody's focus under him. So I really, really liked what they were doing at Chicago. I thought it was a really good model elsewhere. And then at the University of Pennsylvania, one thing they've done recently that I really liked was they have taken mentions of race out of a lot of medical discourse. You know, you open a medical journal and what are you going to read? Description of a patient, 44-year-old, well-nourished African-American man, blah, 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 blah. The fact that he's African-American, why is that significant? Often there's no significance at all. But the fact that you've mentioned that, now you've triggered a lot of people's supposition about who this person is. So they've decided just to remove a lot of that and stop mentioning race when it's not directly pertinent. That's important too. So, you know, institutions are taking steps that mean a lot. And many institutions, of course, are incorporating, you know, courses, text that directly address, you know, healthcare inequities and the history of scientific racism. And that's really important too. So those are the kind of things that I think will really bear fruit.
Thank you for sharing that insight. And so in more recent time, the media has played a huge impact on how many Americans have perceived healthcare institutions. And so with that in mind, what can we do as we are trying to develop ways in which we can atone for our mistakes, address them with action, but still take ownership of our actions without creating an environment that we are furthering the gap in the relationship we're trying to build with communities?
Well, the first thing to realize is I should say that I teach a course in journalism and bioethics at Columbia. I'm teaching it right now. And one of the things I instill in my students first is I tell them, as my fellowship director at Harvard School of Public Health told me, Bob Myers, I never forgot that. He said the media are plural. It's a plural word. And by plural, we're not talking about just numbers, we're talking about foci. You've got the New England Journal of Medicine, that's media. You know, medical media or medical journalism exists too. These are publication, peer-reviewed publications are also part of the news media. And you've got things like New York Times and the National Enquirer, got the Washington Post, and you've got the New York Post, vastly different in resource, vastly different in their focus, their political stance. They're very, very different publications. So when, it's been very common, and I can't always defend the news media, not by a long shot, but it's been very common to lay the onus for a lot of distortion and sensationalization of medical news and advances and issues to the popular news media. But the reality is it's a calculus, it's a feedback loop where a lot of the medical publications are trying to do the same thing. They also are trying to get people to read their stories. And although they're not as I don't want to say crude, they're more sophisticated in the way that they do it, but they also are engaging in sensationalism sometimes, and sometimes in very, let's just say, reports that lack rigor. It happens in the medical media as well. It certainly happens in peer-reviewed medical media that you have a lot of conflicts of interest that militate against accurate reports. Very dramatic sometimes. We have review articles written in medical journals by people who take money from the companies of the products that they are reviewing, a clear conflict of interest. You've got articles in these top tier journals, in Annals of Medicine and New York Medicine that are written by ghostwriters. The horrible thing is that the publication does not always know it was a ghostwriter. And when I talked to the editor of JAMA about this, he declined to condemn it. I'm not saying that he was enthusiastic about it, but he refused to say it was unethical. I think it's clearly unethical to have an article written by, someone at a medical marketing company who's basically giving the marketing message from the drug company and then having a doctor sign off on it for a few $1,000s. That kind of thing happens too. So it's really a matter of, medical media publishing things and the popular media picking it up. And sometimes the root of the problem is medical media, but often it's not. And in many cases, you find that popular media, either out of ignorance or sloppiness or political agenda, whatever, will take a medical story and distort it in ways that can have really dramatic negative feedback. Best example I can think of is the invention of the crack babies. When I was still a newspaper editor, I remember the stories about crack babies. I never saw a published photograph of a white crack baby. They're all black by definition. And it was not only the news media who every day had headlines about how these babies were born addicted because their parents didn't care about them, and how they would grow up to be, golems with no intelligence, no psyche, a danger in the classroom, demonizing children. And the whole thing was predicated upon the mother's drug test. She might have a positive drug test at one point. Whether she had used crack once or whether she used it once an hour, her baby was deemed a crack baby. Then when you go back to the original article, it said no such thing. The original article was a case study of maybe about 20 women dealt with cocaine, not crack. And it said that they found some deficits, neurological deficits, but larger studies would be needed. Well, the popular media went off on that and created the crack baby, but they did it with the cooperation of many, many doctors. Doctors would weigh in, talking about how horrible these babies were, how horrible the parents were. And in the end, it was totally invented. So can you say it was a popular media? Yes. Say it was a medical media? Yes, because the original story was certainly appropriate. But when it was doctors who were riffing off it and offering the dire clinical picture that was not at all supported by the original article. So, it's a problem of, hyperbole. And in this case, they racialized something which had been a report about women using cocaine, no reference to race, and suddenly it was transformed into Black women using crack. So this kind of thing happens. And the only check against it is, you know, popular news media who are become much more diligent about their translation interpretation of medical stories. Some papers do it right. I mean, you got the New York Times, they have doctors on staff, scientists on staff, but most newspapers in America do not. So we need, better vetting, but the medical media also. I think there needs to be a bit of a revolution here. Too many conflicts of interest are considered acceptable, and even like these really high quality prestigious publications have fallen victim to it. And because they are prestigious, I think there's a diminution of the index of suspicion. We're more trusting of something that appeared in New England Journal of Medicine because we know it's high quality, but that particular article might actually be flawed in the way I've described. So we need to do a lot more work here on both sides.
Now, thank you for that. And that's a great point. The media is plural. So, no, thank you. Thank you. Really appreciate that. And so, as we're wrapping up, as a continuous learning institution, just want to just ask one final question. And that's really what are some references or resources would you point the audience to really navigate or take home and really put forth all the things that you've mentioned today into their day-to-day work?
Oh, with pleasure. There are so many. And frankly, I think I'm more inclined to point you to authors rather than books because the authors I'm going to mention are quite prolific. Okay. Dorothy Roberts, hands down. It's actually from her that I first encountered the phrase that racism created race. Beautifully put. Her book, Fatal Invention, is almost everything that you need to know about the invention of race and its consequences. Jonathan Cahn has done brilliant work. He's the one who first analyzed and told us about Beidel and its racial marketing and how it's everything that's wrong in race-based science. And Ruha Benjamin, who I've mentioned earlier, writing about tech and how it affects people of color very brilliantly. Oh, there are so many. For history, there are many too. Let's see. Jim Downs has written several books one talks about the plight of African Americans after the Civil War, the medical plight. I had written about this in one chapter of Medical Apartheid. He wrote an entire book on it brilliantly. And in terms of history of medicine, one of the earlier inspirations was Todd Savitt, who's written a number of books about the treatment of African Americans, enslaved African Americans, largely in Virginia. Very detailed and very helpful. So there are many more, but those are the ones I think are completely essential. Oh, and Stephen Jay Gould, The Mismeasure of Man, is probably the first book I read about dissecting the arguments for African American lower intelligence. And there have been a lot more recently, but he's a classic in the arena.
No, thank you. And we can't forget about Harriet Washington. If you haven't had a chance to read them, I say Carte Blanche. It's out now. I don't know if everyone can see that. And I love Medical Apartheid. I had to go grab them from my bookshelf to make sure that folks knew the cover. Thank you so much for providing us with so much wisdom, so much insight today. We appreciate your presence, and there's so much I know our Office of Health Equity, Diversity, and Inclusion are going to put into action. Really love the history and science are made by people. The economics and politics, we can't forget about that. But thinking about the illogical aspects of medical research and some of the things we do. And then lastly, I really love that atonement. I think that really speaks to what we need to be doing, both in our actions, but then also in our words. And so on behalf of UCLA Health, the Black Leadership Coalition, and David Geffen School of Medicine, I just want to say thank you so much for joining us tonight, Harriet. And it was truly an honor and privilege to facilitate this conversation tonight.
Thank you, Michael. The pleasure is all mine, believe me.
All right. Well, Again, thank you all for participating in this critical conversation, and we're going to give you a virtual round of applause. And everyone have a wonderful night. Take care.
Thank you. Night.